Okay. You are ready? Double check.
Sergio, when you want to come,
Yes.
start, please.
Do you see my screen well? Do you see my screen well? Okay, do you see the presentation?
Yes, we see everything.
Okay, let's start. Hello, dear colleagues. In my country, there are often situations when a patient with an advanced stage of varicose veins wants to treat it minimally invasive. But the surgeon at the hospital or the private clinic says that with a large diameter of veins like yours, you only need to do an open operation. That is to perform prostatectomy with ligation stripping of great venous vein, which is associated with the hospital stay, hematomas, separation from work, and risk of interventional and spinal anesthesia. Such patients come to me and ask, is there any alternative? And the solution is outpatient surgery. I would like to present to your attention my approach to treatment of patients with varicose veins with a large diameter. Conditional definition of large diameter. I consider the diameter of the great venous vein in the femoral junctions from 20 millimeters and more. The main features of performing thermal ablation methods for large veins are the occurrence of heat in the early postoperative period and recognition of great venous vein trunk in the long-term period.
Thank you. Can you give us a minute? Give us a minute.
Okay, I stop.
Okay. Mira lo lento que llega el audio. Baja todo el audio de- Sergio, are you listening right now?
Can I continue? Yes.
Yes, you can start it again, please. Thank you.
From first slide or continue?
Yes, you can go through.
From the beginning, or I
No,
continue?
from
Okay.
from your
My
slide.
equipment,
Yes,
my
yes, yes.
equipment is diode laser with a wavelength of 1470 nanometers, radial fiber, and automatic fiber retractor with adjustable speed from 1 to 2 millimeters per second. To achieve a successful result, technical aspects play an important role. During tumescent anesthesia, a large diameter vein is compressed unevenly around the fiber, and there are always blind pockets that are not exposed to laser exposure and other cause of a heat and recanalization. It might look like this. Here we can see 1, 2, and even 3 blind pockets near saphenofemoral junctions after tumescent anesthesia. Accordingly, the saphenofemoral junctions area should be passed twice, and if necessary, even 3 times. Often we repositioning the fiber, and it can be passed into the blind pocket. I achieve by my actions that the laser energy direct evenly on the entire perimeter of the vein in the osteum, and the energy should be enough to cause the fibrosis of the vein. I always use 10 watt of energy at a traction speed of 1 millimeter per second. Well helps the solution of tumescent anesthesia cooled to 5-6 degrees Celsius to cause a vein spasm. Constant ultrasound control of the position of the end of the fiber is very important. The placement proximal to the saphenofemoral junctions no further than 15 millimeters in order to avoid a large stump. Carbonation should be avoided, since in the case of fiber carbonation, the depth of the mesh to the vascular wall is significantly reduced. To avoid this, I perform repeated passes of the saphenofemoral junctions area at a high speed, 1.5 millimeters per second, and I manually control that the fiber has a free progress and doesn't stick. All the patients I will demonstrate were performed simultaneous intravenous laser ablation of great saphenous vein plus mini phlebectomy of the tributaries plus echo-guided forward form sclerotherapy. Precise ultrasound mapping is very important. The path of the reflux in advance in the vertical position of the patients is indicated by lines. The first key point is the closest point to confluence of the varicose tributary into main vein, and the second is the closest point to the place of drainage, the reflux into the deep venous system. After performing intravenous laser ablation, first we do mini phlebectomy of varicose tributaries at key points. We separate the vicious cycle in the place of the outflow of tributaries from the trunk of the great saphenous vein. Next are the re-entry perforants. Usually this is the confluence site with a medial group of sural veins at the mid-calf level. This is done to avoid getting sclerosant into deep veins. The next step is sclerotherapy, a form of a 1.5% polydecanol solution prepared according to Tessari method. Sclerosant injected in small volumes, 2-3 milliliters at several points. The total volume of the injected form didn't exceed 10 milliliters per operation. The next step is again mini phlebectomy of large varicose tributaries along the path of reflux, usually from the lower part of the thigh to the middle of the calf. The number of punctures is in most cases was 7-8. Advantages to use mini-phlebectomy after echo-guided form sclerotherapy. Spasm of the great venous vein tributaries, the better retrievability of the tributaries, decrease in the volume and traumatism of mini-phlebectomy, the risk of thrombophlebitis associated with fragmentation of tributaries is also decreased, significantly reduced the number of subcutaneous hematomas and the hemosis, and less tumescent anesthesia is required, which helps to reduce discomfort when performing a large amount of tumescent anesthesia. In cases of bilateral lesion of the great venous vein with big diameter, operations should be performed sequentially with an interval of 7-18 days in order to reduce the time of each operation, which in turn reduces the risk of venous thrombotic complication. In all cases, good results were achieved, which were evaluated clinically and using Doppler ultrasound scanning the next day and after 1 and 6 months. None of the patients had thrombophlebitis of the tributaries, which is probably due to mini-phlebectomy, which creates a kind of drainage for sclerosed veins and reduces the likelihood of coagula occurring in the postoperative period. And the frequency of hyperpigmentation also decreases. The combination of echo-guided ultrasound form sclerotherapy and mini-phlebectomy for the treatment of varicose veins reduces the number of adverse events compared with the isolated use of each of these methods. Here we can see clinical cases before and after 6 months, and the diameter of the great saphenous vein near the saphenofemoral junctions for each patient. Conclusions. Simultaneous endovenous laser ablation of the great saphenous vein plus mini-phlebectomy of the tributaries plus echo-guided form sclerotherapy for surgeons allow to achieve effective elimination of vertical reflux along the main vein with a diameter of more than 20 millimeters. And at the same time, they eliminate varicose tributaries. And for patient, rapid recovery for working capacity, good cosmetic result, and minimal negative impact on the quality of life. Thanks for your attention.
Thank you, Sergio. Congratulations, very interesting lecture. We go to the question.
To listening, please.
Yeah, yes, I hear you.
Yes, congratulations. Very, very interesting. We go to the question now. Doctora Sofia Rochet.
Thank you very much, Dr. Kochetkov. It was a great presentation. How many patients do you have with that diameter, more or less? 3?
How many patients? What?
Do you have with that condition, with a big diameter?
I think it's about 3-4 patients per month.
Per month?
Per month, yes.
Perfect. Great number. Thank you very much.
Doctora López Claudia, ¿alguna pregunta?
Excellent presentation, doctor. No pregunta.
Thank you.
Ahora, ¿alguna pregunta?
Look, I have a question for you. I saw that when you are doing the laser cases, you do 3 times the saphenofemoral junction. That is correct?
I do it triple times only in one case when the diameter of the saphenofemoral junctions was 28 millimeters, as in the first slide here in the left leg.
This is the only moment when you do like 3 times. What is the power that you use at the saphenofemoral junction where you leave your laser fiber? How many centimeters from the saphenofemoral junction?
I understand. Up to 5 centimeters to make ability to reposition the fiber again.
Thank you very much. That's great. Thank you. Great presentation.
Thank you, Tom.
There are any questions? Thank you for your participation. Vamos cerrando. Okay. Por hoy estamos cerrando la parte virtual y presencial de esta jornada. Nosotros vamos a seguir, vamos a comenzar, tenemos un paciente que tenemos que ver, tenemos que comenzar el curso de Doppler que va a realizar el doctor Viarte con acá mi gran amigo, el profesor Ríos. Entonces, vamos a ver los pacientes que vamos a tratar mañana. Mi agradecimiento del corazón por la presencia que hemos tenido, por la ayuda de todos ustedes. Así que nosotros vamos a seguir continuando nuestro entrenamiento en la parte ecográfica actualmente. Muchas gracias a todos. Cerramos nuestra sesión de Zoom y mañana comenzaremos de vuelta con los 3 casos en vivo. Hay 3 links diferentes. Hay un primer link para el caso de Flebologia que vamos a comenzar a las 8:30 de la mañana. Hay un segundo link para el caso de Caribe que va a comenzar entre 9:30 y 10:30 de la mañana. Y a continuación el tercer link es para el caso del doctor Caratayud, que va a ser a las 11 de la mañana. Correcto. Les agradecemos por la presencia a todos. Un fuerte abrazo y nos esperamos nuevamente. Gracias del corazón. Desde Paraguay para todo el mundo.
Muchas gracias. Un aplauso.
Excelente. Hasta luego. Gracias.
Gracias, doctores.
Bye.